Good afternoon, everyone. I'm the Scientific Director of the Phelan-McDermid Syndrome Foundation, and I would like to welcome you to our next scientific session, which is focused on neuropsychiatric illness and regression in PMS. We know this is a topic that weighs heavily on the hearts and minds of the community and is a huge priority area for research for us. So today we would like to cover not only the current knowledge in this area and the current resources, but we also want to focus on future areas that we're really trying to bolster research in this area and attack from multiple angles. First, I will share a brief word from our sponsors.
Our mission at Jaguar is to accelerate breakthroughs in gene therapy for patients with severe genetic diseases.
With gene therapy, we can give the opportunity at a better life. That's what makes Jaguar special.
So it is my pleasure to introduce our first speaker, Tazy Kohlenberg. Dr. Kohlenberg is a physician with expertise in developmental pediatrics and in child and adolescent psychiatry. She's an assistant professor in psychiatry at the University of Massachusetts Medical School. Dr. Kohlenberg is also the mother of a beautiful 22-year-old daughter who was diagnosed with PMS at age 16, 2 years after developing complex neuropsychiatric illness. Dr. Kohlenberg has published research on psychiatric illness and regression in people with PMS and has played a leadership role in the development of the PMS Neuropsychiatric Consultation Group, which provides consultation to doctors around the world caring for people with PMS. Welcome, Tazy. We're looking forward to your presentation.
Thank you very much, Kate. I'm very glad to be doing this, and I have to say just a tiny bit nervous, because when you're talking in front of family, it can be intimidating. But here we go. So, because my fingers got very tired of typing neuropsychiatric again and again, we're simply calling this talk Psychiatric Illness and Regression in Phelan-McDermid Syndrome and What We Know Now. And it's really important to say that today's answers reflect today's understanding, today being mid-May 2022. If you are viewing this presentation sometime later when it's been archived, you need to know that our understanding may have moved forward. I sat down and thought about this as a parent as much as a researcher or clinician, and these seem to me to be the big questions that we all sit with. How common is psychiatric illness in Phelan-McDermid? Does the type of genetic difference a person has matter? What does psychiatric illness look like in people like our children? What brings it on? Is there anything we can do to prevent it? And what sorts of doctors could help us? And I want to start with a caution. I know I'm preaching to the choir here, but some symptoms that could be considered psychiatric are part of the baseline wiring for some people with Phelan-McDermid, and we need to distinguish them. I'm not minimizing their impact, but they are different from the onset of a new psychiatric condition. And so this list of, disrupted sleep, which is so common, the restless sensation-seeking profile that some children have, difficulty focusing, aggression, often sort of playful or impersonal aggression, repeating, shouting, compulsive behaviors, eating things that aren't food, and head banging and other forms of self-injury can all be part of someone's profile from the get-go. So I think it's important to lay a foundation, and I would advise parents to take videos every year that show behavior, communication, motor skills, self-care skills, and favorite activities, not on people's birthdays because everybody's a little different on their birthday. And also at least sporadically to keep a record of sleep patterns and bowel habits, which we know are closely related to behavioral change for everybody, but especially kids like ours, and of behaviors that are beginning to concern you. This kind of background foundational data is a huge help. if new emotional or symptoms or behavior develop, and you need to look back and figure out when and how they started. And they're also useful for educating your child's healthcare providers and school staff. And if behavior changes, think of pain and explore medical causes. This list would be familiar to anybody who spends much time on our family support pages. And I'm not going to read it to you because you can read it for yourself. So starting on the question of the nature of psychiatric illness in Phelan-McDermid, in 2012, a group in Belgium published a paper which was interesting because they had looked at 7 people who were identified when 4,000 people with intellectual disability were tested, 7 people who had Phelan-McDermid, ages 5 to 51, and they then evaluated those 7 people in detail. And what they wrote was that psychiatric disorders were common, in particular bipolar disorder and attentional problems, that some had had sudden deterioration after stressors, either medical events or social stressors, and that all had had some degree of loss of skills, though with this age range, that could encompass a lot of different things. And they speculated, and we're still speculating, that a deletion affecting SHANK3 might result in a dysfunctional nervous system, that is, a nervous system that was not well wired and not resilient, that was more susceptible to developmental problems and psychiatric disorders, less able to recover after stressful events, and more vulnerable to degeneration over the long term. And those points are generally supported by our experience as a community and by further research publications. But there are some limits to the studies that have been published so far, including my own, which are that most are studies of people with Phelan-McDermid who were already psychiatrically ill. And studies like that can help us describe the patterns of an illness, but can't tell us how many or which people will develop those problems. Because of this, the natural history study is critically important. It's following a group forward through time. And the data hub will also be an enormous resource. So this is a pitch to remember to go and enter your data. I'll start with question 1. How common is psychiatric illness in Phelan-McDermid? And this question doesn't have an answer yet. We know of at least 140 families who are currently dealing with psychiatric illness in their loved ones with Phelan-McDermid, who are connected through English-speaking social media, which is a somewhat elegant way of saying Facebook. We know about 20 more in French and Spanish-speaking countries. The age range is large, from 10 to their 50s. We assume there are people out there we haven't met yet. And at this point, all we can say is that psychiatric illness is not uncommon. Number 2, does the type of genetic difference affect the odds of developing a psychiatric illness? Maybe. It appears, note the verb appears, that people with SHANK3 variants, the spelling errors just in the SHANK3 gene, or shorter terminal deletions are more likely to be diagnosed with psychiatric illness. That may be because the more skills a person has, the easier it is to recognize. I don't know, but still more than half of the reported cases were in people with larger terminal deletions or ring 22. Number 3, what can psychiatric illness look like in people with Phelan-McDermid? Pretty much everything. On this list, you see anxiety and obsessive compulsive disorder, aggression, the mood disorders, so mania, depression, and bipolar, psychosis, catatonia, and regression, which isn't strictly speaking a psychiatric illness. And I sort of took as my mandate today to let you see some of what this looks like in kids like ours. So we're going to rely heavily on videos. People with Phelan-McDermid can have symptoms that fit with multiple psychiatric diagnoses at different times. And I'll use our child as an example, because starting at age 14 and ending at age 18, she had 10 distinct illness episodes, including severe mania several times, usually with her period, depression, psychosis, severe OCD, and then finally catatonia. And this range of types of episodes is not uncommon in Phelan-McDermid and psychiatric illness. I'm just going to give you this vignette of her several years before the onset of psychiatric illness to give you a sense of who she was and mostly is.
Tell me again.
Can I please have the carrot when I get home?
Oh, what kind of carrot do you want, Bunny?
A little carrot because I'm an Easter bunny.
Okay. Marty needs to get shoes on, Bunny.
You think I'm naughty? Can I stay inside?
Okay.
So, anxiety disorders and obsessive compulsive disorder. Now, those two used to be in the same group until they rewrote the diagnostic manual recently, but fundamentally, anxiety disorders are diagnosed when a person has fears or fear-driven behaviors that interfere with their usual function. And OCD involves obsessions and compulsions, which is why we call it OCD. And these can be hard to clarify for our families because repetitive behaviors and obsessions are pretty common at baseline. And people who can't use language well can't always let us know what they are feeling or thinking. Am someone chatting to me? No, okay. So what anxiety and OCD can look like includes these things and others, but mainly refusal to go places or see people they used to enjoy, new fears, irritability, agitated behavior. Some families describe their children trying to escape or grabbing frantically at their caregivers and almost climbing them like ladders or trees. And I think of those as possible manifestations of panic. An increase in self-soothing behaviors such as rocking, clapping, a new need to do things in exact sequence or do them over and over. And again, we're talking about new, not something that's always been there. Repeated questions looking for reassurance and not being reassured, and signs of adrenaline overload, the fight-flight response with restlessness and diarrhea, trembling, being pale, having very dilated pupils. Here is our daughter at age 16 when she overnight developed the fear that something bad was going to happen to our cat. And for the next few months, she needed to be within a few feet of the cat at all times. And even when sitting watching the cat sleep, would ask if the cat was safe. And she also had facial tics and odd twiddly movements of her fingers, sobbing spells, new pee accidents, which suggested a somewhat controversial diagnosis of PANS or PANDAS. In this video, we're driving to a doctor's appointment and she's in distress.
They took my cat away. Tell me what you know. Tell me. They took my cat away. They took my cat away. That's not real. Tell me what you know. My cat's in my house in the playroom. That's right. Did not take a cat away? They did not take your cat away. Why not? Because that's not a real thing. But they did. I saw them do it.
So this went on and on and on, and it didn't respond to psychiatric medications that were tried over months. And so she was admitted for a big medical workup. She was actually seen by 6 different specialist teams. And although Boston Children's Hospital doesn't like to use the diagnoses of PANS and PANDAS, they agreed that she was severely ill with something very acute that looked like a kind of autoimmune brain disorder, And so they tried treating with intravenous immunoglobulin and a course of antibiotics, and she got better and life went back to normal. Now, I'm not going to show you a video about depression because I think really as a culture, we know a lot about what depression looks like. People lose interest in things they used to enjoy. They may seem withdrawn and not respond as they usually do. They may have sleep changes in either direction. They may sleep more or they may have insomnia. But if they have insomnia, they're exhausted, unlike mania. They move slowly. They seem listless. They can look sad or fearful. They can be irritable. They may have a change in their interest in food, and they may lose their ability to care for themselves, as neurotypical people do during severe depression as well. So then mania. I think most people have not seen mania, and bipolar is a phrase that's being used a lot more perhaps than it should be in the culture. Mania involves a spell of days to weeks or even months during which a person sleeps much less but doesn't seem tired. That's probably the one single most identifiable symptom of mania. They have high energy and they talk or vocalize faster and more loudly. They may be excited and extra happy or cranky, and they may be giddy or bossy. They might do impulsive and dangerous things that they wouldn't have done before. They may have new intense repeating behaviors, or they may come up with goal-directed projects, such as organizing or giving things away, or in the case of one family I've spoken with, a whole project for a dog walking business. This is the beginning of a manic episode, and this person is silly, loud, and impulsive.
Hey, calm down.
You want to tell the forum.
Stop.
And this is a teenager who's in a speeded up manic episode, lots of clapping and loud speech.
By the way, do you have to touch some monkey? You have to touch some monkey. You have to touch some monkey, mommy.
I can't right now, Bo. Maybe you could relax a little.
By the way, monkey, you have to get a monkey. You have to get a monkey to the head down. By the way.
And finally, here's another young man in a manic episode. And one of the things about mania is there's an aspect of it that can be joyful. And I would say that he's joyful. He's exhausting, but he's joyful.
Oh, check your pants. Check Grandpa's pants. Oh boy, check Grandpa's pants. Oh boy. Oh boy.
And oh boy, at the bottom of the stairs are a whole lot of things he threw down. Moving on to psychosis. What psychosis can look like. Psychosis can be seen in mood disorders, in severe depression or in mania, and it can also be seen in the primarily psychotic disorders like schizophrenia. It can be difficult to be sure what you're seeing with people who don't or can't communicate their ideas, but you're looking for hallucinations. So they seem to be interacting or reacting to things that others can't see or hear. Delusions, if they can communicate their thinking, they believe things that cannot be real. They can be disoriented and they can have really bizarre behavior that's really startling. This is a 19-year-old who's probably having visual hallucinations. She's gone through a period of months in which she was constantly watching something that others couldn't see and often talking to it in a whisper. She wasn't distressed. She was, if anything, amused, But she was so preoccupied with this that she stopped caring for herself. She stopped eating. She stopped being able to shower independently. She had a long, high-quality video EEG that showed no correlation between the behavior and anything electrical in her brain. And these symptoms, in fact, resolved slowly over several months without new medication. So next we'll talk about catatonia. Catatonia is a fascinating syndrome, not actually a single psychiatric experience. It's a disturbance of movement and behavior that can accompany a range of different psychiatric and medical conditions. And it's more common in people with neurodevelopmental disorders, particularly in autism. In the study that I conducted interviewing parents of 40 people with PMS and psychiatric illness, the parent descriptions suggest that it's common, and they would often say yes to enough criteria to make that diagnosis. But it seems that the diagnosis is often missed, and if it's missed, it's not treated. And sometimes the altered state can be then attributed to regression as part of the syndrome. Catatonia can be a stuporous form, which is characterized by slowing, odd sustained postures and a variety of other findings, and a hypermotoric or excited form. And both of them can converge on something called neuroleptic malignant syndrome, which is a very severe form of catatonia that affects multiple organ systems, can be life-threatening and requires ICU care. All of the forms can be triggered or worsened by antipsychotic medications. This is a 30-year-old who was hospitalized for mania and agitation and given 2 different antipsychotics and developed this, which is stuporous catatonia. She had had a fall while on the psych unit and then vomited and aspirated and required ICU care for several days. After that, she was sent home, but she was very changed from who she usually was. She was staring and stiff. And 2 days later, she was admitted to a medical unit at a second hospital because she couldn't walk or eat. She remained in this staring, stiff, and shaky state in the second hospital for over a month. The team there thought she'd had a brain injury, either from her fall or from aspiration and low oxygen levels, and their recommendation was that she should go to a long-term care facility. Her family knew of the possibility of catatonia from our group and advocated that she be treated. Here she is before she was treated for catatonia. And that's pretty much how she was for a month. Ativan helped a bit, but the hospital wasn't comfortable pushing the dose up to the high levels that are required for some people with catatonia. And she was eventually treated with ECT, which resolved her catatonia. Whenever I show you these really worrisome and hard videos, I like to show the afters. Here she is this spring, back to baseline. She's been stable for over a year. And she's rocking. So here's another similar story. This is a girl who developed manic spells and hallucinations at age 13. And she was started on an antipsychotic, risperidone, which caused probably muscle stiffness and trouble eating. And she was hospitalized for feeding. The risperidone was stopped and she went home, and as outpatient, she was started on a different antipsychotic. And about 6 months later, she developed the changes you see in this video.
Why don't you stand up straight? Now, doesn't that feel a little better? Can you hold your head up?
So she wound up in hospital and needed ICU care with a feeding tube for nutrition. This is her, I think, before the ICU. Ativan and intravenous immunoglobulin were tried and were not helpful.
Swing your feet around.
Notice her hand position here.
All right, here you go. Keep going. There's your right one. And swing. Good job. All right, let me scoot. Ready? All right, get your feet straight. Can you straighten your feet, uncross them? All right, you ready? All right, straighten your knees out.
Hold your head up.
Push, push, push. Hold your head up too. All right, lock your knees. All right, can you take steps to the chair? Whoa, whoa, whoa.
So they decided to try ECT, and here she is after her first ECT treatment.
Good job, you're playing.
So she finished the sort of primary course of ECT, got therapy, which I think is really important for our kids who've been through this sort of episode, to relearn walking and feeding. And she went home improving steadily. And this last video is of her about a year later, going up for her belt in karate.
That's what I'm talking about.
Yay, Sarah!
So that was the stuporous form, and now we're going to look at the excited or hypermotoric form of catatonia, which is trickier. Many doctors will never have heard of it or seen it. I'm a child psychiatrist. I've never heard of it or seen it. It can be hard to distinguish from severe mania, and it often begins during mania. And these are some of the more common symptoms that I hear about from our families. And these are all very new and different for the individual. They're not the background symptoms that they've had all along. Restlessness and pacing, tens of thousands of steps a day, new oppositional behavior that's not typical for the person, fast and mumbled speech, and sort of progressing trouble with oromotor coordination. So trouble with saliva, with drooling, holding food in the mouth, but not chewing or swallowing it, or outright refusing food. You can see new repeating of words or phrases, and repeating of gestures as well. An odd symptom that seems to come up more for our kids is frequent, brief, and unproductive trips to the bathroom to pee. There's usually tremor, and there can be changes in where the blood goes in the system. So red, flat blotches on the upper body, and hands turning white and purple, sort of as if they were extremely cold. This is our girl in excited catatonia. It shows you slurred speech and repeating. She had had a first seizure during this catatonic episode. She also, I don't know if you can see it, but she has a strong facial flush, and she's started drooling. So she's got a towel to catch the drool.
I think Jojo forget it by now. I think Jojo would forget it by now. Didn't Jojo forget about it now? I love Julia. I love Julia. I love Julia. I love Julia, right? I love Julia.
So that's the condition she was in, and she got intravenous Ativan, and here she is 30 minutes later, completely back to her normal self, with typical speech and movements and behavior. And this change lasted until the Ativan wore off, which was about 4 hours later, and then all the catatonic symptoms returned.
They kiss us and then turn over and kiss us. And I get so surprised.
You'd be surprised.
Yeah.
Sure you would. We all would if she came in dressed as a nurse.
Kiss me.
So the catatonia and seizure brought a new diagnosis of presumed seronegative autoimmune encephalitis. Now, autoimmune encephalitis is described in the book and the movie Brain on Fire, and it's a fascinating disorder. Presumed seronegative means it looks like it, but we can't find any markers in the blood or spinal fluid to confirm it. Whatever it was, she started receiving intravenous immunoglobulin, which is a powerful immune modulating intervention every month along with the psych meds she already took. It's been 3.5 years since starting those monthly infusions, and she's had no further serious psychiatric episodes, although she has occasional bumps. And I want to show you this is what better looks like. She was in art class?
Yeah, and I can't remember her name. She was a woman teacher and she liked me. And me and her could do this and that, but the teacher who was the other teacher, who me and the other teacher couldn't do this and that because she was not a big hugger.
Oh, so, all right, moving on from catatonia to regression. Regression is a big concern for PMS parents. We know that some children lose skills in their early years, and what's sort of typical for a certain kind of autism, mostly by age 3, a handful later. There are also a handful of people with Phelan-McDermid who experience skill loss in middle childhood, but the next big group that has skill loss is in the teen and young adult years. And I think it's really important to note whether the loss of skills comes and goes with episodes of illness, in which case I would call it an illness-related behavior, or lasts for months after an illness episode when the person is no longer ill, in which case I think we think and talk about it as a regression. So in our study of 40 people with PMS and psychiatric illness, loss of skills was common after the onset of psychiatric illness. It was reported by 2/3 of the group, and the skills were lost across multiple areas of function. About half of those regained some or all of those skills when their mental health stabilized, particularly if they received rehab services focusing on recovery of those skills. There's a much smaller group of individuals who are over age 30 with psychiatric illness that we're in touch with. Some of those have had dramatic loss of skills, while others lose skills during episodes and regain them in between. We can't yet predict what this will look like with time and supportive treatment. Question 4, what brings it on? Well, psychiatric problems in Phelan-McDermid typically start during puberty and young adulthood. And they are often after a stressor, such as a medical stressor, or when services and supports change, like aging out of school, or at times of family transitions, such as a sibling leaving home, or a move, or a death. And they also happen after being exposed to certain medications. So these are some thoughts about medications to avoid if you can. The interviews we've done with parents about the course of their children's illness and what they were treated with point to a need for caution in the use of antidepressants, particularly the SSRIs like Prozac or Zoloft. All of them have 2 names each, so I won't recite them all, because they can trigger first manic episodes. And antipsychotic medications are associated with a high rate of side effects, and in particular with the development of catatonia when they're used in people with Phelan-McDermid. And I want to finish this slide by saying this does not mean that such medicines should never be used in Phelan-McDermid. They are used in some. There are people who need them. There are people who tolerate them fine. There are people who benefit from them, but they should always be used with caution and close observation for these complications. And if other medications are available for whatever you're treating, it may be better to start with those other medications. Is there a role of inflammation? Maybe. There's, in general, a lot of interest in the ways that infections and inflammation are involved in psychiatric and neurologic illness in general. We're seeing this with post-COVID psychosis. We've seen it for a long time with systemic inflammatory diseases like lupus. There's a gluten and schizophrenia connection. So we should be interested because it's possibly relevant, and also because people with Phelan-McDermid may well have immunologic differences related to SHANK3's role in immunologic signal processing. There's also a small group of people, my daughter among them, with Phelan-McDermid and psychiatric illness who've improved when they were treated with immune modulating approaches such as IV immunoglobulin, antibiotics, and anti-inflammatory medications, often after many psychiatric medications were tried without relief. We don't yet know why this should be true. We don't know who this approach may help, and we have to just stay tuned. Number 5, is there anything we can do to prevent these problems? Well, first of all, we don't know if there's any way to predict them for an individual, and we certainly don't have guidance on prevention. But this list is sort of common sense interventions that one could consider, always in consultation with your child's medical providers if it involves ingesting anything they otherwise wouldn't ingest. I think buffering stress at transitions is critical. And Kate mentioned our daughter's about to be 22. That means she's about to fall off the cliff of education to the rest of her life. Bridging relationships and familiar spaces across those connections or any other life transitions makes an awful lot of sense. Keeping constipation well controlled is really important, and keeping teeth and gums clean is important because we already know that the inflammation that can develop along the teeth and the gums is connected to inflammatory illness in multiple sites in the body. We want to maintain a healthy diet, and we want to make sure that the micronutrients like minerals and vitamins are actually being absorbed, not just delivered in the top, but getting into the system. And I think it's reasonable to consider supports for metabolism and to buffer biologic stress. And that's going to be addressed by Lance Clausen, who's doing a talk this fall on using nutritional and metabolic supports for the vulnerable brain as part of this virtual conference. And finally, this is not so much prevention as early intervention. Build a team in your area who've met your child and who can run alongside or be in the background if you need them. Question 6, what sorts of people, what doctors can help us? Since so many of our kids also have seizure disorders, it makes sense to have a team that includes neurology and psychiatry who at least have an initial consultation and get to know the individual, who you can call if and when you need them. Psychologists have a great deal of knowledge to contribute across many of these areas, their anticipation, their management, their treatment. And I want to note that because Phelan-McDermid is so rare that most providers will not have experience with it, and particularly with this, managing the psychiatric manifestations, it's really helpful if the team is open to seeking consultation when there are unusual issues. So in summary, people with Phelan-McDermid can develop severe psychiatric illness. If they do, it's usually in their teens and 20s, and it often resembles bipolar disorder with distinct mood episodes interspersed across times of baseline. These problems are diagnosed and may be more frequent among those with small deletions or with spelling errors in SHAG3, but they can happen as well in those with large deletions in ring 22. People with Phelan-McDermid can have unexpected or intense adverse reactions to certain meds. Catatonia is unusually common in people with Phelan-McDermid who have psychiatric illness. Psychiatric illness can be followed by loss of skills or regression, with skills regained in about half the cases. And some families of our sort of PMS senior citizens describe, and psychiatric illness describe, a long, slow decline over years. Thoughts about treatment? Well, figuring out the best treatment regimen for any individual with Phelan-McDermid is complicated, and it's really individual, and that's been frustrating and fascinating. In general, there's a prescribing principle of start low and go slow, and there is clearly no one-size-fits-all approach. So there are resources that we've developed, and Kate mentioned the PMS Neuropsychiatric Consultation Group, which is a project of the ECHO program. It's also called the PMS NCG, or the ECHO team. And it was formed to support doctors who are caring for our rare patients when they have psychiatric illness. We provide in-depth video case consultation to doctors all over the world. We're on, I think, our 36th consult, and recently intensified the program from meeting once a month to twice a month. The team also developed treatment guidelines, which are available through the foundation website. You can download them, you can look at them, you can share them with your doctors. All of this is provided free of charge by dedicated and generous experts. It was founded with the support of the foundation and the Seaver Center for Autism at Mount Sinai, and most fundamentally, Alex Collison. Here are the members of the NCG right now. You'll see that there are people mostly in the US, but also in Italy and the Netherlands, and a lot of big name institutions. Some of these may be doctors that you've already seen. And we're just incredibly grateful for the time and thought that they bring to this work. And I want to close with thanks to the families, first of all, to the families who've participated in the research, shared their stories, and allowed me to share their videos today. To my co-authors who helped me to put the parent interviews into a rigorous research context. Could not have done it at all without their involvement. To the foundation in all the ways that it leads us and supports us, to all the doctors who care for our children, and again, to the experts who donate their time to the consultation group month after month. And with that, I'll stop, and we'll take questions later, I believe, after the next presentation.
Thank you, Tazy. That was fantastic. That was incredibly informative. And I know we at the foundation are so thankful for you and what you do every day to support families. And I know the families are too. Tazy is correct. We will take questions at the end. And just a brief update, Joanne Boomer, who I'm about to introduce, will speak for about 10 minutes. And then I will share one slide just for a couple minutes to talk about some initiatives that we have coming up to support more research in neuropsych. So I would love to introduce Joanne. Joanne is a registered nurse, parent to her son, Jared, who has PMS, and also parent to his 3 brothers and sister. She's a wonderful advocate in the community and has graciously offered to share her family's story in neuropsych illness and PMS. She will share a brief PowerPoint and also a video. Thank you so much for joining us, Joanne.
Hi, everyone. So I'm out in San Diego, and I'm just going to go ahead and get started. I'm going to show you the PowerPoint, which is just a comprehensive overview of what we went through in the last year. And then I'll be going over to a video that we put together for you guys to just kind of see when I talk about regression or loss of skills, what we were seeing, also the catatonic for us anyways, what it looked like, the slowing down and the staring and the gazing. So without any more interruptions, I'm just going to share my slideshow with you. Here we go. I'm going to start the slideshow for you. Just making sure, can you guys all see that first slide?
I can see it, but it's not in presenter view. If you would like to do slideshow under the slideshow tab.
That's where I thought I was at.
And if not possible, the main slide is the largest. So if you would like to advance them this way,
There we
that
go.
works too.
Does that work now?
Perfect. Yep, can see that.
Okay, so just a little background. Jared is now almost 21 years old. He was born in June, and the date of onset was of his catatonic stupor was last in 2020 when he was 19, and it lasted through 2021. So we did visit the doctors throughout the entire process. Initial visit was in June in person. The rest were all via telephone until November. But we did notice right away that Jared was having a really good behavior days. We were really excited as a family because he was not eloping out of the house or causing mischief. So that was all really helppful for everyone in the family. And I'm going to stop my video so you guys, okay. So then as a family, we were just happy about the good days. He seemed more compliant, easygoing. He started to sleep through the night without any medications for sleep. He had less noticeable behaviors, and the weight loss was contributed to him not having school food or the extra incentive snacks that they were giving him at school. And he just was becoming more and more compliant with directions at home. So we were all super excited. Then in September, we noticed significant changes that were actually happening throughout the summer, but more noticeable after we'd gone away for the weekend and had come back. There's more significant weight loss. Jared seemed very fearful or afraid at times. He didn't have normal activities. He wasn't doing those. He needed help to do all his normal activities of daily living. He started having difficulty with walking, and I attribute it to a Parkinsonian gait, shuffle pattern, a slowness. He had a fixed posture and freezing. He did have tremors and shivering, and his extremities became really cold more than usual. We noticed his fingers were colder. Multiple times we called the doctors, and they didn't want to bring him into the clinic because that was the height of the pandemic. And they just ordered blood tests, and they kept saying everything was perfect. Everything was good on the low normal range, and they weren't concerned. He was still losing weight. At this point, it was closer to 40 to 50 pounds, but it was still within the normal BMI for his height. But to us, Jared looked too skinny. It was taking an additional 90 minutes to eat food. We had to encourage him to swallow, to chew, and he was having difficulties just eating. And at some point, the family, we all began feeding him bites of food just to encourage him to eat more. And we instituted giving him protein shakes at home to supplement his meals, because we did notice he wasn't eating enough, and I felt like weight loss was too rapid. Any voluntary activities were very limited. He didn't go and do his normal get into trouble, mischief around the house, or go do extra things that he wanted to do. And remember, California was on a lockdown, so it was significant that he was doing less and less. He required assistance at one point to ambulate through the house. Walking, we had to guide him. He would get stuck or frozen, and you'll see that in the video I'll play in a minute. While he's eating or doing an activity, he would just stop, and we'd have to redirect him to keep going. And all of the non-compliant behaviors that our kids show had stopped, even with non-preferred activities. And so that was interesting as well for our family to notice. So at that point in October, I'd reached out to the family on the PMS Facebook group on Jared's weight loss. I think I might have posted a photo or just asked somebody, is this normal? And then immediately was redirected by parents to the echo team and to Tazy, or Dr. Kohlenberg. And then she did reach out to me. We went over different documents and the echo team treatment plan and just over Jared's normal activities and what was to be expected, what we would see with him. Ultimately, the doctors brought him in, but we ended up having coverage through Naval Hospital Balboa, and they chose to treat Jared for his catatonic stupor. And the lead doctor on that was Dr. Jacqueline Serena, the pediatric neurologist at the Naval Base San Diego. Ativan trial was done at home since to comply with COVID-19. There really wasn't a placement for him in the psychiatric hospitals. Everything was locked down. So we didn't want to send him to a psychiatric facility with no family involvement. So we chose to do the Ativan trial at home. A lower dose was initially given and we didn't see a change in his behavior or mood. And then they gave us a higher dose to challenge, the Ativan challenge, and it did work. And immediately his voice movement, everything, it was almost like he was returned to normal, and you'll see that in the video as well. But during that time in October, when we're waiting for the doctors to give us a diagnosis in October, November, we didn't know what was going on. And as a parent, we were just kind of losing our mind, as most of you can imagine how stressful that would be to watch your child decline. So immediately I started getting Jared involved in whatever activities I could find in our shutdown pandemic world here in Southern California. And we found a yoga teacher that was doing a group yoga twice a week. And it was for all the disabled kids. It was out in the park. It was like an illegal activity, but he allowed anyone that wanted to come. It was unsanctioned by the school, but we went. We did get him in horseback riding, and it took 3 people to get him on the horse initially. It was just really crazy. We did end up starting ABA therapy, and then we started to, I don't want to say force, but encourage or robustly get Jared involved with any activities that the family was doing, whether someone was running an errand to the grocery store or going to the park, or going to 7-Eleven, whatever that, just as much getting him outside of Jared's catatonic stupor. He actually was very labile and wanted to sleep in bed all the time. So if we came in the house, he would just go straight for his bed. During this time, he still required a lot of hand-over-hand prompting and guidance. So our treatment was Ativan. We started with 1 milligram times 1 a day dose, and increased due to the short interval of improvement. So Ativan is short acting. So we did have to increase that based on his needs. So at the end, we did end up going up to 3 milligrams 3 times a day at the highest dose. We did our own taper, again, because of the shutdown here in California. Things still weren't open. It was very difficult to get into the hospitals, but I was in phone contact and emails constantly with his neurologist at the Naval Station. And we were able to taper his meds back down. And then by the end of May, he was completely tapered off all of his Ativans. And the other meds that we had been holding, his medications for sleep and mood and behavior during the day, we slowly started gradually putting those back on after May. It took about 3 months to go back to his full dosing. I just put a list of his medications for anyone who wanted to know what those medications were. As you can see, they're pretty standard for our Phelan-McDermid kids. He had some Claritin or Sertraline for allergies, melatonin for sleep, trazodone for sleep, clonidine for mood and behavior. We do give him gummy fibers, and Zofran. Occasionally he does get vomiting cycles that don't stop, and he is highly allergic, so we do have an anaphylactic pen, which we don't have to use unless he, of course, is having anaphylactic shock. And then I just want to thank everyone for being here today and listening. We do hope that in some capacity, this slideshow or the video will trigger something in you. You'll remember it in some way, and that you guys will know, can refer back to this. But I do want to say just thank you to my family, the kids. His adult siblings were here during the pandemic, living at home, and without their help and support of their younger siblings, I don't know that I would be able to take care of Jared and pull him through this phase of catatonic stupor that he has gone through. I did list at the end here the articles that Dr. Kohlenberg had sent, and also a book that I found helpful, and I just listed them on the last slide. I believe this slideshow will be available for you guys at some point if you have any questions. As a parent, I just wanted to let you know that I just feel it's super important that we share information that's happening to our children, the good, the bad, and the ugly. That's how we learn. And I really appreciate this article, the neuropsychiatric decompensation articles, and the ones from Dr. Kohlenberg, because they really put in perspective what you're seeing, but then actually seeing it in person, sometimes it doesn't correlate together. So that's why I put the slideshow together. So what you'll see is a transition from Jared in 2019 all the way through this spring. And you'll see his face change where he is super smiling and happy and his eyes are alive, and you can see he's in there, to being withdrawn and to the point where he is needing treatment, and then to recovery and back now to where he's back to his happy, jovial self. And we're so glad that we were able to get the help that we needed. So now I will start a video for you guys.
Jared, where are you going?
Oh!
Time to go to work. What are you doing, Jared? Are you working? Jared, what are you doing? Tell those guys to go to work, huh? You like that train, huh, Jared?
Joke?
I want to hear a knock knock joke. Yes, please.
Knock knock.
No, who's there?
Who?
Who?
Is there no one there?
Is there an L there? Oh, you're so silly. Is that your watch? How many watches are you wearing? Oh, you have 2 watches on. Tell me something today.
Watch.
Oh, watch.
Are you getting my house? Are you getting the house? Oh. Ah! You got the water. Ah! You got Mom. You think that's funny? You're doing a good job watering. Do the plants need a drink? Go get it, quick. Who's coming home? Allie's not coming today. Who's coming home from the bus? Is it Wyatt or Anthony? Anthony!
I hope you guys enjoyed the video, and it just gives you a glimpse of what Jared is able to do now, and you can see his facial expressions back, and he's really happy.
Thank you, Joanne. I know I appreciated seeing his smile, and I'm sure many others did too, including his knock knock jokes. So we really appreciate it and know it takes time to put together those videos. So I'm going to share just one slide. I'm just going to take a couple of minutes to talk about some of the current initiatives that PMSF is focused on in this area, and then we will open this up to Q&A, and the session will go until 5:30. So we'll get through as many questions as we can for Tazy and Joanne. So I will just share screen here. Can you all see that okay, I hope? Just somebody interrupt me if you can't. So I wanted to illustrate that PMSF is constantly thinking about this area of research and how to increase more research. And so there's a number of initiatives that we're very focused on right now in the neuropsychiatric illness area and regression. So the first is our Young Investigator Award. This is a relatively new initiative. It is a PMSF-funded year-long project with the opportunity to extend for 2 years, either with the same candidate or additional candidates who will apply. The person who was selected after a competitive review process by our medical and scientific advisory committees is Asif Rahman, who is an MD and has experience in child and adolescent psychiatry and will be mentored by Dr. Alex Kolevzon at Mount Sinai. He will begin his year July 1st, 2022, and some of his major aims are to analyze data that has been collected from the Neuropsych Consult Group and from the Natural History Study. As Tazy mentioned, there have been a lot of consults within Neuropsych Consult Group, and there has been also a lot of data collected in the Natural History Study, and this will serve to characterize and analyze some additional layers of data there. And he will also collect new data by following up with families and clinicians in a very thorough way to continue to understand and inform the best clinical guidelines based off of what worked and what the results were in implementing those therapeutic strategies. Would also really like to identify or continue to elaborate on preceding and contributing factors to these psychiatric episodes. A couple other things I want to mention about the Young Investigator Award are that the biggest thing is that we are supporting someone's a good portion of someone's salary and time. So this will allow more than 50% of the time that Dr. Rahman has to be devoted to this. We have a very extensive group of talented advisors in science and medicine, but they also have full-time jobs. And so a lot of what they are doing is taking extra time out. And so we are very thankful to have somebody who will have a large amount of time dedicated solely to this, which we think is a big step forward. Another thing to note is that we will make his application and specific aims public once the contract is signed, and that is happening very shortly. There's just some tiny final things to work out, but everything is moving forward, and he will be starting July 1. So we're thrilled that he will be joining us. Another thing that we are working on doing is increasing the volume of the Neuropsych Consult Group consultations by doubling these number of referrals so that more physicians throughout the world can meet with our advisory teams within this group that Tazy so well laid out. We are also adding a neuropsychiatric illness and regression survey to the data hub. This will be in addition to the surveys that are already there, and we will send out some information when it is available. We think this is one of the best ways to get information from many different people, whether or not they're able to visit the clinic or not, whether or not they're able to get a neuropsych consult or not. Everybody will be able to fill out this survey, and so we're trying to collect that data, and we will then analyze that after we have it open for some time. And finally, we're really working to collaborate with other groups. So any other groups with neurodevelopmental, that represent neurodevelopmental disorders with a neuropsych component. We're starting with Kleefstra syndrome and working with their leadership to learn what they do, what works for their population, and continue to refine these guidelines on therapeutic intervention. So we will continue to focus on this area in the future. We understand the impact that it has on families, and we really see it as, if not the highest priority, one of the highest priorities for devoting resources in science and medicine. And we will definitely always keep you posted on that progress. So with that, I will take a look at the Q&A and direct those questions to Tazy and Joanne, and we'll try to get through as many as we can before 5:30.
Looked, but as a parent, I can just tell you, you always know your child best. So use your gut instinct and keep advocating if you feel like the medication or the dosing isn't correct, because you just know your child best. That's all I can add to that.
Thank you. Okay, so our daughter is almost 7, and we've seen mild bouts of what was described today, but she will come out of it typically, can last anywhere from a day to a week or 2. At what point would you seek additional help?
So I think this is the point where I would start looking for a really good collaborative psychiatrist to meet you, to meet her, and to run alongside. You may not need to do anything about this. It may not worsen. Of course, I don't know the specifics of what you're dealing with, but in terms of having someone who knows your kid and who you've developed a working relationship with, this is probably a good point to do that.
Thank you. The next question is, can 7-year-olds have symptoms of mania?
Yes. It's not the typical age for people with PMS to start having this profile that we've talked about. So I would say the question is, were those kind of there all along as part of this person's profile and way of being, or are they having distinct episodes? And if they're having distinct episodes, yeah, it can happen.
Thank you for that. A couple of the other questions in the Q&A are specific about medications, so we'll see if they can be answered, and if not, we can always follow up. We have a question that says, what about using Lamictal for depression in a person who also has epilepsy?
So Lamictal is one of, also known as lamotrigine, is one of the medications that we're seeing as most successful for a lot of our kids with mood disorder. I don't know that it's a great antidepressant, but it's a decent mood stabilizer. And of course, it also is useful for some kinds of seizure control. Again, kind of points to the need for a collaboration between neurology and psychiatry.
Thank you. Question about Ativan. When doing an Ativan increase to treat catatonia, what is the recommended dosage increase and frequency of increase?
So I'll point you to the flow sheet of recommendations that the ECHO team has put together. I've learned from the big expert on that team, because I certainly have not had a lot of experience in managing catatonia prior to my own child developing it, and now knowing so many other people. But in general, the recommendation is to give it 3 times a day and to increase by about 0.5 milligram at each time every few days, guided by any sedation and improvement. So some people, when you first make a dose increase, they do get sleepy and groggy, but then that wears off and you see the benefits. If you get to a point where the sleepiness and grogginess doesn't wear off, you may have maxed out the benefit you're going to get from Ativan and need to actually step back to the previous dose and look at other approaches such as ECT.
Thank you. And I wanted to reiterate the resource, which is the pharmacological guidelines. They're available on our website, and the NCG has done a fantastic job putting them together. And Tazy has sent these out periodically along with publications that are relevant. And so we'll make sure that everybody can be pointed to these resources, if not already.
And they are in the files section of most of the Facebook pages too. So you can pull them out there. They are based on everybody's best judgment. They are not based on research. We don't have research that looks at these questions, but it's the pooled wisdom of that long list of kind, smart people that, and sometimes we modify a line or two.
Thank you. And I just got a message from Diane that they're also available in the conference app. So that's a nice thing to have along with this session. The next question is, in the research, how many people have had prolonged catatonia that is untreatable? Or probably rather than how many people is it commonly seen?
In the research, no. That is, the publications that are out there don't describe it. We do know that it has happened more like recurrent or insufficiently managed. That I don't mean to imply anything about the management, but that people get somewhat better, but then it comes back and they don't get all the way that you want them to get to. That's what I'm aware of. Mostly people respond well.
Thank you. Is there a way that you would suggest to discuss with a psychiatrist or other physicians the possibility of IVIG treatment if it's not being received well as a suggestion?
It's really tough. Now, there are a couple of reasons it's tough. One of them is it's not yet a standard of care. So there's one publication, the first author is Bey, B-E-Y. I'm on that paper as well. And that's 4 teenage girls, each of whom had severe psychiatric illness that wasn't responsive to normal psychiatric treatment, and a lot of it. Each of whom eventually responded to immunomodulatory treatment, either IVIG or other immunomodulatory treatment. And each of whom was in the course of the evaluation for their intractable illness, discovered to have a SHANK3 variant and diagnosed with PMS. So that paper is really the only publication so far that looks at the possibility that immunomodulatory treatment could be helpful in our group. There's sort of 2 additional things that we talk about, but they're not data and they're not standards of care. And one of them is that the SHANK3 protein it's basically like an I-beam in a certain kind of cell junction, and its main job is to hold a receptor called NMDA in position to bind to the thing that wants to attach to it. And NMDA receptor encephalitis is the brain on fire thing that really got everybody's attention. So there's some thought that because people with PMS have unusually structured receptors because of the SHANK3 deficit, that they may have something very like NMDAR encephalitis. And that's a pretty sophisticated argument that I think would be hard for somebody who wasn't in the field to convincingly make. We've beaten our head as in a number of cases against that. Well, and it doesn't always work or anything like always work. And it's terribly expensive, which means that systems don't like to just try it. And I think just continuing to bring forward the case reports of people who benefit is the best we can do to support families who are trying to convince doctors. And I know that's not a lot of help, Françoise.
Our son has been undergoing ECT almost weekly since January of 2021, working to decrease aggression. Is there a concern about this going on for too long before seeing brain damage?
I am not an ECT specialist, and I feel uncomfortable answering that question with great confidence. I would rather you reach out to me through Kate, and I can connect you to our ECT expert in the consult group, and you can get a better answer than mine.
We will catalog any questions we don't answer today and make sure to get you an answer. So I will make sure to note that question. There's also a question where I can follow up with some resources that asks, are there any upcoming clinical trials addressing neuropsych and PMS? If not, are there any plans for some in the future? So I could start with that answer, just that there are several trials that have some endpoints that or assessments that are looking at behavior, but I'm not aware of current clinical trials where the primary focus is some of these more severe neuropsychiatric symptoms as of yet. I think the hope is that anytime that we see any improvement with these clinical trials, that we would expand the assessments to see how much it helps different symptoms. But I'm working on circulating or developing a clinical trials resource that can explain all of the assessments that either have been tested or are being tested for previous and current clinical trials. And if Tazy wants to add anything to that, she's welcome.
So I think it's a really pressing need. And those of you who know me know I've been chewing on the ankles of the people who might do something like this for the last few years. It's really hard to design a trial. And that's, we're not there yet, but I think it's a really important need. And what exists is more assessment batteries of developmental function. And that's really important too, but intervention trials that look rigorously at what might help stabilize our kids are a whole different beast, and we need it.
Thank you. We have a question that says, are there known older PMSers who haven't had neuropsych episodes beyond their baseline?
Yes, but they don't tend to hang out on the Facebook page because they're not in crisis and they're not necessarily looking for support. I'm really eager to find more of those people and talk to them in depth, but yes, they exist. And I see two more questions here that we haven't talked about.
I was just about to ask you about, so a couple of them are very specific to cases. I was going to ask if you were comfortable with me asking them or if we want to address them in any other way.
I'm not sure which person is asking about severe catatonia because it's just a first name, but if you want, you could put them in touch with me. And the other person who's asking a specific knows how to reach me. And that, what I'll say in general about this kind of question is that this is what I meant when I said that the approach is highly individual. There is no one size fits all. So to some extent, these questions are asked in the hope that there's a protocol to follow. And beyond our guidelines, I think it's really a lot of fiddly, exploratory, careful work with a lot of observation and collaboration. So happy to talk with people more to share ideas, but maybe not to imply a level of certainty that doesn't yet exist.
Thank you. And please, anybody feel free to email me and I will connect you to Tazy or to others if we didn't get to your question or if it was very specific. And there's a comment. Oh, sorry. I was going to say there's a comment in the chat, but Tazy had her hand up.
Oh, I just wanted to mention about the regression that in general, I know I touched on this in the talk. I think intensive rehab intervention, as you would for a person who'd been in a car accident and had a head injury, is really something to fight for our kids who have been this sick, that expecting them to get back to their previous baseline on their own may not be realistic, because we know the nature of the deficit in Phelan-McDermid means that acquiring and consolidating new skills is enormously time consuming, and there's a lot of backsliding. You get something and it's gone the next week. And so when those skills have been lost, they need a lot of scaffolding and repetition in some people to come back. And that's a general point, not just for that specific question.
Thank you. That's really important. We have a comment from Cynthia that I think is also a really important comment. It says, as a parent having gone through catatonia and having spoken to many parents who are struggling through catatonia, I can't stress the importance of having regular interaction with a psychiatrist when you feel these issues may be a concern. For us, a psychiatrist has been a lifeline for a connection to the PMS ECHO team. So I just wanted to thank Cynthia for that comment. I think it's an important one for everyone.
And in the consult group, we've had times where they couldn't get the psychiatrist to interested. Sometimes, unfortunately, you have specialists who think they already know everything they need to know. But primary care docs can sometimes be wonderful. So I wouldn't say it's only a psychiatrist who can avail themselves of this consult. A good primary care doc, family medicine doc, can be quite wonderful. And in other countries, I've learned access to specialists is much less than it is in the US. So different models.
There's also a comment that says, document everything you can, videos, spreadsheets, photos. That's really important. We know that especially the videos are very helpful for the neuropsych consult group to understand more of what's going on, and also to continue to define these categories in our community. So this is, of course, voluntary, and we're working on having more infrastructure around this to have consent and a place to share these videos. But I think that's an important comment as well.
Yes.
And I don't think I see other questions, and I think we got through most of them. So again, if we did not address your question to the group, please write to me and I will try to make sure it gets answered. And want to thank everyone for their attendance today and our speakers for an incredibly informative session.
And Kate, can I just say, it was really helpful, like Cynthia pointed out, and the documenting video spreadsheets. I didn't have documented spreadsheets, things like that, but we did have a doctor that had seen Jared prior to his catatonic stupor. So I think it is important that you maintain at least one physician that knows your child at baseline, so that when things go awry, they can definitely know that it's different than before, right?
Yeah.
Like Jared uses his device to talk, and then he wasn't using it at all, and he would ask for a bean burrito every time he sees a doctor. We'll tell him, okay, we'll get a burrito if you're good at the doctor's appointment. So the doctors said bring him in and then see him in the state of catatonic stupor and not ask for anything. They immediately knew something was wrong because he wasn't his jovial hello, how are you self. Please make sure that you're consistently following up with your pediatricians and physicians that treat your child at all different times, because that's what really is going to make a difference too, for them to help you. I feel like when they know your child at baseline and then see this change, that's when we got the most support and help from those physicians. And if you're like me, you don't do spreadsheets and you don't know, at least that can be helpful for the doctor and you to try to go back. And we do take a lot of video of our families doing different crazy stuff. So most people have an iPhone or some kind of phone to record. Those are simple, great videos that you can look back on and kind of determine and see where the transition might happen or have happened. So I just want to put that out there too.
Thank you. That's great advice. And we also have another comment in the chat that documentation helps with insurance coverage too. So documentation seems to be helpful across the board. So I think that wraps this up for today. Thank you all for joining. Thank you to our speakers, and we will see you next time.